So I'd like to invite the three other previous speakers to please come up to the desk. We will now have a discussion period, and if we can have the house lights up, please, and the screen up as well. You're going to sit down here?
And just to tell you something, just remind them that the whole purpose of the round table is to get together in terms of cohesion or consensus, whatever, and that probably will put this together in the special issues on the comments on the whole issue.
Okay. There's a wireless microphone, at least one, that we will be walking around with, and so we'll ask you to signify you have a question by raising your hand, and not only questions but also comments or observations. In designing these group discussion or roundtable, no, for the audience, please, sessions, we want to try to synthesize what we've heard as much as possible to achieve the complete puzzle that Norberto has challenged us with. So we want to, in our discussion, try to do a bench-to-bedside, bedside-to-bench synthesis of the information. And perhaps I'll start by asking Ed a question, which is, given your work and your colleagues' work in identifying part of the thalamus as a way to turn up the gain of excitability, if you will, do you think that it could be, and you mentioned memory and apathy and behavioral changes, but may it also influence some of the other comorbidities that we've heard about here clinically, and if so, how can we take the information and apply it clinically? And I'd ask Vera and Andy to comment on that as well.
Good. Okay. We'll hope this works without a lot of feedback. It's a very complex question, Steve, as you probably figured as you were asking it. One of the things that in the animals, we know that there are significant problems with memory and other behavior as well, depending on the animal, the test models that we use. Drawing an exact parallel between the animal behavior and human behavior is often difficult, especially when we're trying to sort of correlate things like anxiety and depression, and also psychotic behavior. Although the rats that have epilepsy are behaviorally quite different than normal rats. We argue whether it's aggression, whether they're showing whether anxiety, whether they're hyper-responsive. But I think one of the problems that we run into in terms of trying to correlate behavioral changes with pathology is that in some cases we really don't know the full extent of the pathology. We do know that in these animals, in addition to the thalamic pathology, which is specific to the midline, the medidorsal, and other limbic nuclei, there is a significant damage to the lateral septal nucleus and to the hypothalamic nuclei, among other subcortical regions. When I first described the behavior of our rats in terms of their being very hyper-responsive, anybody who's dealt with one of these epileptic rats, they recognize the behavior immediately. You don't like to handle them. A friend of mine who is what we call a rat runner, one who does a lot of behavioral work with rats, said that sounds like a septal lesioned rat. And there's some evidence, I think, that in some of in people, when they look at the MRI scans, there may be some damage to the lateral septal nucleus as well. So in terms of trying to correlate the pathology, it's a bit more difficult. Are they good models for testing out human therapies? Biologically, that may be true. we don't know. No one's really tried because we don't know what test to run. One of the interesting things in terms of the biology of this is, especially in looking at the severity of hippocampal atrophy, if you look in the psychiatric literature, one of the most common imaging findings associated with depression is hippocampal atrophy, hippocampal volume loss. And it's run, they say it's as often as high as 50%. If they sort of get, especially they get when the diagnosis is made and then look at it a year later. It's not clear whether that gets better if the depression goes away, whether it's a reversible volume loss or not. But clearly, there's something with the hippocampal pathology or hippocampal volume and depression which goes hand in hand. And again, whether in this case in people with depression and epilepsy, whether one is enhancing the other, it's not clear. But I think there is as Andy and Vera said, there's a clear neurobiological substrate to this as well, and I'll let them comment on that.
There are some interesting behaviors that have been seen in association with deep brain stimulation. I don't know if you want to comment on that. For example, in the Sante trial or in deep brain stimulation for Parkinson's disease, you see some interesting behaviors, and I don't know if that may be some clue also into the specificity, of targets for inducing behavioral changes. But any comments from Andy or Vera?
I just wanted to expand on what Ed was saying, and that in the volumetric studies that have been done in patients with patients with primary major depressive disorders, and this is work done by Shalin and collaborators at Washington University in St. Louis, they've actually defined a circuit of neuroanatomical changes in the brain that involves the thalamic structures. And so it's not only the hippocampal formations that are affected, but it's the hippocampal formation, cingulate gyrus, thalamic nuclei, and basal ganglia. And so it's this whole circuitry that is affected. And I think that's why I think the findings that that Ed discussed were quite interesting to me, because it really supports further that common pathogenic mechanism story that one can see in these two sets of conditions. Whether it's an association or causality, we don't know, but it's it's part of the puzzle that it's.
Any comments or questions from our audience? Don't be shy.
I just like to comment one point. That's when we talk about children with depression and anxiety disorders, we see that different from adults, we don't have much alterations or gross alterations in the hippocampus structures. And you talk about brain stimulation. I don't have experience with deep brain stimulation, but when we talk about VNS, we can see that children, even if they don't give much better from seizure frequency, they have a mood improvement with this kind of stimulations, peripheral stimulation, not the deep brain, but we can see it in the clinical sector. So I think it's more, I don't know exactly what's going on, because we have children with almost normal image, and they are very important psychiatric comorbidities. So I think it's not really clear for all of us.
Thank you. One of the interesting experiments that have been done with vagus nerve stimulation, I forget now who did this work, is if you chemically lesion the locus coeruleus, then there's no anticonvulsant effect of vagus nerve stimulation. So it could be that same center is, in releasing norepinephrine and so forth, is important in the mood effects that have been described. In fact, in the U.S., vagus nerve stimulation is approved for the treatment of depression. Please, sir.
Morning. I just would like to ask to Dr. Bertrand about the influence of basal ganglia and brainstem substrates to your thalamic model of seizure control. And to Dr. Steve Schaster, if we could think that some kind of grassroots circuital alterations could be behind epilepsy and other comorbidities. Thank you. Two questions.
Let me make clear that I understand my portion of your question. You're asking for because I missed, I think, the first part of it. You're asking about the substrates for the seizure control, or?
Yeah, the seizure control connections as relations of basal ganglia to the seizure control connections you're describing thalamus.
Okay. At this point, it's all very speculative. Because I don't think we really have a good understanding of the complete circuitry, especially we know we can talk about parts that are involved in the circuitry. We know the different parts, we can point out these are the different areas that are involved. As I was talking with Marcia last night, I think one of the things when you think of circuits, each circuit has different nodes, and you can interact with that node in the circuit in a lot of different places. And if you control one node, you can control the behavior of that circuit. You know, we talked about sort of the primary circuits involving the thalamus. The thalamus is clearly a node. Is that the place you can control things, or should you look at, we really begin to focus on understanding, which we really haven't done. Glure years ago looked a little bit at some of the subcortical mechanisms or subcortical regions for controlling thalamic behavior, but you know, which potentially brainstem or midbrain nuclei that you could look at, which can influence the thalamic excitability. That's a wide open question. And I think knowing the anatomy and then sort of being able to demonstrate that you can physiologically modulate those areas without really disrupting overall behavior. I think one of the things that really tells us that we can somehow modulate the system to sort of dampen down the effect is the very common clinical observation that even though there are these permanent changes in the brain that are associated with epilepsy, and they're there all the time, they push the system towards excitability, people don't seize all the time. They can sometimes, many of these people can go, even if they're not on medications, can go for weeks without having a seizure, and then they can have several. And so one of the questions is, what's happening in the system that sort of allows that to push it over? Because if you could understand that aspect of it, if you could modulate it, somehow you might be able to, without really significantly changing, using a lot of medication, you could prevent the seizures in a fairly simple way. But we have to understand the circuits.
And if you could kindly repeat the second part of your question.
It's about circuital alterations that could be behind a kind of grassroots alterations that could lead to epileptic states and the comorbidities. So if you think that there could be some kind of behind circuital alterations from that could make origins to epilepsy and the comorbidities.
I'm sorry, I'm not quite clear about it.
Yeah, if you believe that there could be some connection alterations in some brain parts that could originate epilepsy and the comorbidities. So both epilepsy and comorbidities could be a consequence of other inside alterations, not apparently seen kind of metabolic disease, metabolic insufficiency, or other biochemical alterations that could lead to both epilepsy and comorbidities.
Could epilepsy and the comorbidities come from a common cause? Is that? Yes, absolutely. I think that's very likely in my mind. And that what determines whether one or both become manifest may be other mediating factors as well. And also what the temporal sequence with which they appear may be influenced by mediating factors. So we may, there are certain lights, when you flip the switch, that take a long time to come on. There are other lights that when you flip the switch come on right away. And if you just saw two lights turned on and the one came on first and the second one came on later, you may incorrectly conclude that the fast onset light caused the slow onset light to come on, when in fact there was no relationship between the two lights, but really in the underlying mechanism for each one. Depression and epilepsy, for example, if they came from a similar underlying cause, where one is like the smoke, the other is the heat of a match, we need to be careful in inferring too much from the temporal sequence, I think, with which one preceded the other, because it may be that the factors determining when depression or epilepsy becomes clinically manifest are unrelated to the interrelationship between the two. And it makes you wonder if depression is associated with hippocampal atrophy, and a patient presents with seizures and is found to have hippocampal atrophy on MRI scan, but doesn't have a history of clinical or overt depression, might they nonetheless be in a depressogenic phase preceding the development of epilepsy, and hence when depression does appear after the epilepsy begins, it's not that the epilepsy unmasked the depression, it's just that it took longer for the depression to become clinically manifest. So these are hypotheses or conceptualizations, but we need to be careful in inferring too much about the concomitant or this sequence with which these become clinically apparent. Andy?
Yeah, I think, the question of causality, I think we're very far from inferring causality here. I think we're at a stage of just making observation that there is an association, but it's a very complicated story, and I think we're just looking at the tip of the iceberg, because while people with depression, based on these population studies, have a higher risk of developing epilepsy compared to controls, the number of people with depression that develop epilepsy is small. So in order for you to make this observation, you really need to do population-based studies with huge number of people. But the actual number of people with depression that go on to develop epilepsy is not that great. So if there was actually, similar, pathogenic mechanisms that are causing one or the other, we would see a much greater magnitude of a problem. And I think that it's a cumulative effect that is playing a role in different ways that have to do with a whole variety of pathogenic mechanisms interacting in different settings, and where genetic predispositions also have something to do. But what causes what? I don't think we're there yet to establish real causality.
Other questions? Norberto?
Yes, I think one of the intentions in having this panel, basically with different approaches, with basic scientists and clinical people, neurologists sort of attracted more from the so-called neuropsychiatric part plus the neurology part of epilepsy, is exactly to point to the complexity, but at the same time the adding information coming from different approaches, different views. And I think we need to move forward in terms of the recognition that complexity is a problem that needs to be approached with complexity tools. So I think the computational neuroscience has helped a lot in terms of simulating things that you have no time in real life to process. And from there, just to go to the bench or to the clinical area and try to see if the predictions coming from the algorithms are actually real things. And I think the concept that epilepsy is coming from somewhere, I think is kind of a simple way of seeing epilepsy. But at the same time, let me take an example from the clinical experience. When the people use lamotrigine, for example, they see Touretteisms as a side effect. For a basic science point of view, Touretteism is a biomarker of something that is happening, like a tic phenomenon, like a compulsive ritual, very specific, coming from a circuit. So it's not exactly a bad thing in a model of epilepsy. It's a bad thing for a patient that has treatment with epilepsy, but the Touretteism has a side effect. So if you look at different circuits, like a circuit explaining epilepsy at the same time, a circuit antagonizing epilepsy, but showing something else, that means you have two circuits sort of competing, and the outcome will be the prevalent circuit. So we simulate several circuits at the same time working in fMRI with 3D reconstruction shows how many circuits are indeed associated with the expression or whatever we do or see in diagnosis. So I think we need to sort of change maybe the dogma that the explanation is simple, because we're recognizing each time more and more that the number of factors is extremely big. So modeling and going to the bench or the clinical side and coming back to the modeling, etc., is a way to sort of speed up things and to learn more from both sides. I think Marcia can sort of complete some of these things.
Please, Marcia.
Yeah, great lectures. It's actually horrible to be able to, because I have to prepare my lecture for the afternoon. I changed it completely just by listening to what you have to say. And I have one question that's almost in the same line that Dr. Norberto is going through. When you look at specific physiological events from a bottom-up perspective, like how does sound processing take place, visual processing take place, and you don't look at it from a top-down modulation, you miss a lot of the control mechanism, the feedback control mechanism. So in most of the cases in which the results from transient response, like evoked potentials, you stimulate a specific area and see how other areas of the brain behave. If you don't do this in a steady state evoked response manner, wouldn't you be missing something? So the question here is, if you did the stimulation in a steady state form, in which you would not allow the 30 milliseconds to pass by before you gave another stimulant, do you think you would broaden that very specific target in the thalamus? Or even more than that, would you recruit other substrates that might play a critical role in modulating the seizure? So just to make a very strong connection to what Professor Norberto said, when you look at this in a steady state point of view, you start recruiting a lot of endogenous oscillators, gamma oscillations, tether oscillations, that would actually modulate the flux of information. And from the physiological point of view, this would be a sensory motor integration. But in epilepsy, this could actually modulate this epileptic circuit, this epileptic oscillating reverberant circuit. So the question is, should we look at this in only transient points of view to study it, or should we look at this in a steady state response, because that would be closer to what physiologically is going on?
You have unfortunately pointed out the weaknesses in a lot of the work we do. And that is that, you know, when we do these tests, what they're really designed to do is show the systems are different. If we really get into, you know, what's actually happening on a moment-by-moment basis, these tests really are not good for it at all. And we can get different responses and different findings depending on if we do repetitive stimulation and watch the change of the response. We can see different responses there. It's just more data to analyze, and so we try to avoid that because we just like to keep things simple because it's easier to analyze. And so, you know, we were talking about last night is that when you do field recordings, which is what, especially if you're doing over a long time, you're not doing intracellular, you're not looking at the responses of individual neurons, you're looking at populations. One of the great difficulties that we have is that as you place your electrode into the tissue, you can get a very different pattern of activity depending on just on moving the electrode tip a half millimeter or so. And so one of the great difficulties you run into then is reproducibility. And then unfortunately biology has a lot of very individual variability. So then trying to take a circuit activity with the massive amounts of data and trying to see then how these things are different becomes phenomenally complex. And I think the truth actually lies, and especially for some of the comorbidities in terms of how things work, that these are the more important questions. It's just that technically, for just the performance of this and for reproducibility, it's a far more difficult question. And so, you know, we like to keep with a simple-minded kind of a do a stimulus, see a response. I've got a difference, and I'm happy with that. But I think actually when you get down to the really how do the systems function, especially at different points of the interaction. I mean, using inhibition or enhancing inhibition, it depends on where in the circuit that you do it. And the spike wave epilepsy, absence epilepsy is a classic example. If you inhibit the cortex in these models of epilepsy, of spike wave epilepsy, you can stop the seizures. If you inhibit the thalamus, you'll make the seizures worse. So it just depends on where in the circuit that you're interacting and what the pathophysiology is, and that you just have to be able to look at the whole circuit.
Would it be okay just to add a part to this? It's really fast. Just to say that part of the results that you got, one thing that's undeniable, you have an oscillatory event in only the epileptic animals. In single pulse electrical stimulation of patients that was done by Gonzalo Larcon, published in Lancet, and with Mark Richardson in London, they saw the exact same thing. And this was not a stimulation that was conducted specifically at a site. They were using this to try to find out the seizure onset zone, and secondarily, how would the surgical prognosis be? So even in that sense, this could be used to look at these micro seizure domains and look at if they are epileptic or not. So in that case, you would cut off a little bit of the external modulation, I think.
So this is a question for the whole panel. So it's come up a number of times over here.
Okay.
That we don't know the relationship between epilepsy and depression or anxiety and these other disorders. And I wonder if you have thoughts on specific animal models or experiments you'd like to see done that you think might address some of these questions. And I suppose it could be clinical studies as well. So just open that up to the panel and hear your feedback.
So I think, you know, there are animal models of the genetic absence epilepsy rats of Strasbourg. There is a nice animal model that displays the comorbidity, if you will, between the phenomena that is equivalent to depression and anxiety symptoms in the rat to what would be in humans. Both before the onset of the seizures and after the onset of the seizures, the investigators in Australia used the sucrose consumption test to test the equivalent of anhedonia. So, and since rats love sucrose, they saw that these strain of rats consumed less sucrose than controls. And when they were exposed to the open field maze, which is an animal model of symptoms of anxiety, they also exhibited less, they left shorter distances from the center of the maze, suggestive of greater equivalent symptoms of anxiety. That's the best that I think we can put it. The Gepper rat also is a nice example of a comorbid animal model because those rats have audiogenic seizures. And when you look at the phenomenology of psychiatric symptomatology, they also have decreased sucrose consumption, they have increased immobility state in the prosult immobility test, and also they have decreased locomotor activity that has a diurnal variation, which is equivalent to what you see in humans with diurnal variation in and decreased growth hormone secretion. So these rats have a decreased serotoninergic and noradrenergic arborization in there. So those are nice animal models. The most exciting animal models, I think, are the ones that have been done separating the rats from their dams at birth and then subjecting them to rapid kindling and showing that those rats that were separated from their dams compared to those that were reared by the dams kindled faster. So using those animal models, you start seeing this kind of data that is supportive of these comorbid common pathogenic mechanisms that exist. But the big question is, are these tests that are used as animal models applicable to the human? You know, this is for you guys in the basic science to decide, you know. I'm just a clinician.
Any other comments from the panel?
I'm just going to say, Andy, no, we don't know when the rat's depressed. You're going to have to tell us whether the results are applicable to humans or not.
Vera, let me address a question to you. And you mentioned autism as a comorbidity of epilepsy, and it begs the question as to how important is a clinical manifestation of a seizure in concluding that there's a comorbidity of epilepsy with something like autism, or is there another marker that's more important, such as the interictal discharges, which are found in up to 40 or 50%, for example, of children with autism. So are we perhaps missing part of the spectrum if we narrow our classification system or our thinking to epilepsy as reflected by actual clinical seizures, or should we also look at subclinical seizures without apparent clinical manifestation, or very frequent time-dense epileptiform discharges as potentially interrelated with conditions like autism and potentially treatment targets?
It's an interesting question, but difficult to respond. When we look at the clinical practice, we see two sides. One is that patient that have clinical seizures with lots of discharge on EEG, and maybe normal or abnormal image, and have some symptoms that are common with autism. These patients may not have the classical autism, or maybe part of the spectrum of autism disorders. The other side is that patients that have may have subclinical seizures. We see that some patients with clinical autism, when we look at the EEG, we see lots of discharge, especially during sleep. And this is really difficult for the clinician to define if who is the better to identify the classical autism. I think that classical autism should be that one that don't have discharge on EEG, and in these patients we see, in some studies we see that there are abnormal volume in MRI, especially in the frontal areas. In patients with epilepsy, this is not so clear. And I think it's really difficult to define what's the symptom of the EEG pattern, what the symptoms of the mental retardation, and what we can classify as autism. I don't think we have a good answer for this question. Don't know if we can have another idea about that, but I don't think we have a good answer for that.
Yeah, I mean, I think the only thing that we have with comorbidity are the observations that kids with autistic the spectrum disorder, by the age of 15, 30% will have epileptic seizures. The EEG, 50% of kids with autistic spectrum disorder, 50% will have epileptiform activity, but we don't know whether the epileptiform activity and the seizures are an epiphenomena of whatever caused the autistic spectrum disorder, or, which is what you were discussing earlier as to the different processes of the comorbidity. So it's just at an observation at level.
Other questions from the audience?
As I am a biologist,
Okay, please.
I generally apply an evolutionary perspective over scientific investigation. So my question is that, considering mental health might be not a counter-adaptive emotional response in different environmental scenario for an epileptic patient or animal, should we consider that might evolutionary scenario have selected common pathways in epilepsy and comorbidities? And the other question is that treatment strategy should consider this perspective.
Unfortunately, there's a lot of echo
There's a lot of noise.
in this room, and so we apologize. It's difficult to hear sometimes the question.
Okay.
Maybe to speak a little more slowly so the echo goes away in between words. That's perhaps the best we can do.
Okay. My question is that, considering mental health might not be a counter-adaptive emotional response in a different environmental scenario for an epileptic animal or patient, considering evolutionary science, should we consider that this evolutionary scenario has selected a common pathway in epilepsy and mental health comorbidity, and treatment strategy should consider this perspective?
So one of your questions, if I understand, should we incorporate the treatment of the comorbidities into the treatment of the epileptic patient?
If this,
is that what you're
if
referring
this
to?
emotional response in epileptic brain, such as stress, anxiety disorders, and depression, could be considered as an coevolutionary pathway selected over time, as an not as a counter-adaptive selection, an opposite view of a pathology.
Are we completely misinterpreting the significance of comorbidities as pathology when in fact they may be, they may have evolutionary, they may lend evolutionary advantage to those affected? Very interesting question.
And this, the treatment should apply this view and this perspective, consider not as it's an overreaction of brain or emotional response, to adapt this in this new reality of us as society functions differently in the selective environmental when brain was selective and adapted.
Well, it's a very, very fascinating question, and I think clinicians are very simple-minded in the sense that they...
I'm a biologist.
Yeah, we see a patient suffering, we think they're suffering, and we want to help them. And certainly the comorbidities we're speaking of impact negatively in today's society, today's culture, on these patients. And so they become targets for treatment, therefore. But, perhaps there are other comorbidities that have a positive impact that we simply ignore or don't measure right now that could be interpreted, as you suggest, as lending, as having some evolutionary value. This is reminiscent of, the concept that seizure-induced hallucinations may have some evolutionary value that may, lead to the formation of new religions and so forth that shouldn't be viewed as a symptom of disease, but as a, inspiration from some other source. Clearly, the, interconnections between structures, in the mesial temporal lobe and, hypothalamus, for example, have a purpose, and it may be that, and of course excitation plays a significant role in development and so forth. So I think one way to think about this is that the very reason that, or the reasons that may predispose to these comorbidities may have evolutionary significance. It's just that in a subset of patients, the process carries to a point where it becomes disabling or, what we interpret as disease. Andy?
But there is, I think this is very much to your point. There is one study from New York that looked at whether offspring of parents with depression had a higher incidence of epilepsy. So it's not anymore if you have depression, are you at greater risk of epilepsy? And the answer is yes. So there may be something that is not just restricted to the individual, but they may have a genetic, connotation. And the other big question is, what is the impact of treating effectively the comorbid psychiatric disorder, for example, on the potential risk of developing epilepsy if, in fact, the occurrence of depression is a risk factor for epilepsy? And if you were to prevent the occurrence of this psychiatric comorbidity, do you limit those risk factors? I don't think anybody knows that. Those are the questions.
One argument to your point is another set of comorbidities we haven't talked about yet, and I'm not sure we will, and that's the neuroendocrine dysfunction that can occur with temporal lobe epilepsy, manifesting, for example, in women as amenorrhea, or so in other words, the rate of infertility in particularly women with temporal lobe epilepsy is higher than in the normal population, healthy population, and so that would argue against an evolutionary advantage to that in as much as they would not be able to have children. Ed, were you going to say something?
I was going to say when you interpret sort of the behavioral issues associated with epilepsy, there are a couple things that we need to keep in mind. We've been talking about, and please correct me if I'm wrong, is sort of we're looking at epilepsy as one big population, and in this population of epilepsy, we're saying that the epilepsy, and this is going to turn to a question from my colleagues here in a minute, but what we don't know is if there is a type of epilepsy which is more prone to depression than others. Is there really is there a certain substrate so that people with, say, mesial temporal lobe epilepsy are far more likely to have depression than people with frontal lobe or one of the neocortical epilepsies that has a different physical substrate? The other piece in this, in terms of the evolutionary disadvantage or not, you really need to put I think with Keams we didn't really talk about as much today, is that epilepsy occurs in a social context, and there are some societies in which epilepsy is an absolute terrible thing to have because of all the consequences and burdens. In other societies, it's neither here nor there, and whether that affects the incidence of all the psychiatric comorbidities or not is less clear. My little anecdote is that in the last 20 years, I've owned 3 dogs, 2 of whom have had epilepsy. And the second one, we decided not to treat, and, you know, at that point, he didn't hold a job, he wasn't driving, so having a seizure every now and then was not a big deal. And the only way it really affected him in a negative way is if he had a seizure around supper time, his sister would eat his dinner, and he would never know the difference, and he might lose the best place on the bed if he had a bed seizure when he was sleeping. So there was, but otherwise, you know, he was a pretty happy dog. So I think the issue too is you have to put the epilepsy not just in a neurobiological perspective, but in the social context as well in terms of the environment. That does play a very significant role. I think there's some studies which have shown that. So I've got 2 questions for this group, and maybe this will answer some of this as well, that's your question. We talk about depression and as a binary thing. You either have it or you don't. And it's sort of like their populations. In reality, and you correct me if I'm wrong, what we're looking at is sort of the happiness scale, that there is it's a normal distribution, and the question is, if there's a cutoff point which we say you're happy or depressed, that is really a case that just epilepsy, if you look at the peaks of the population, it's not a bimodal, everybody's happy except this one group, and then the rest of these are normal, or is it really in epilepsy the population is just shifted? So that whatever we draw the line, you just have more, you have still a normal distribution, but the whole epilepsy population in general is just shifted towards the depressed, or psychosocial, whatever. That's number one. I'm going back to the other question I asked. Is there any evidence that some particular forms of epilepsy are more prone to psychiatric comorbidities than others?
So the first question is there a bimodal, a binary separation? The way that I conceptualize depression is, depression is a lifetime condition, as opposed to happiness and sadness. Or, I mean, we all have episodes of being sad as a reactive process to this and that. But when you have depression, it's a lifetime condition. And this is something that you can prove when they developed the monoaminergic theory of depression. What they did is they took people with histories of previous history of depression, they challenged them to tryptophan-free diets, and patients with a prior history of depression developed symptoms of depression. But patients without any prior history of depression or family history of depression did not have any impact. And the same thing, they were challenged with inhibitors of the synthesis of norepinephrine. People with a history of depression, but not symptomatic, had breakthrough symptoms of depression. And people without any prior history of depression did not. So what happens is that you have this predisposition to suffer from mood disorder that come and go. And depending on what's going on in your life, those risks come up to the surface. And if you take a careful history of somebody with a history of depression, they will tell you that, you know, they have periods of time when they become symptomatic and then it goes away. And there is a very, often you can see a relationship between what's going on in their life or not. So I think the separation of, the binary separation of yes, no, I think it's artifactual. And I think for research purposes, we use these scales and this and that to identify. I think that's arbitrary, and it probably just tells us a part of this history, because in reality, clinically, patients have what we now are identifying as subsyndromic forms of depression and anxiety, where they don't meet the criteria suggested by the DSM category. But the impact on the quality of life of these people is significant. So I think that one thing is research, the other thing is what you see clinically at the bedside with the patient. Now, for a long time, temporal lobe epilepsy was associated with a higher incidence of depression. But actually, as we're becoming more and more sensitive about the recognition of comorbidities, there is evidence that people with frontal lobe epilepsy have as high an incidence of depression as people with temporal lobe epilepsy. It's just that people with frontal lobe epilepsy were not being investigated. And if you really look at the literature on post-surgical complications, psychiatric complications, post-surgical psychiatric complications of frontal lobectomies, there is nothing. Whereas there are a lot of literature on temporal lobe epilepsy. So I think it's just an artifact of what has been studied. But in fact, one of the most important studies came from Brazil, from the University of Sao Paulo. Armando Filho was the first author, and he described a high incidence of depression in frontal lobe epilepsies. And so it's, I think it's going to, at the end, be what you were talking before. We're talking about circuits. It's not anymore one structure correlates more with this condition or that condition. It's a circuitry that is affected in a neuropsychiatric condition as well as in epilepsy.
Okay, so coming close to the end of this session, I want to express a message of hope and excitement, particularly to our young students and young scientists in the audience, that when you hear people like us with gray hairs, complaining about, not complaining, but voicing uncertainty and complexities and challenges and unknowns and unmet needs, those become your opportunities and should encourage you to dedicate your careers towards solving what are identified at this stage as the most vexing problems in the area of epilepsy and comorbidities. I would just like to conclude perhaps with a controversial or thought-provoking concept that comes back to our biologist question about the value to the individual in a reproductive sense, or the value to society of epilepsy and comorbidities. Ed mentioned that various cultures view epilepsy itself as either representative of evil spirits or as neutral, or in fact there are other cultures in which the person with epilepsy is viewed as having special supernatural powers that are of benefit to that group, that culture. An example of that is the Hmong, H-M-O-N-G, where the person having a seizure is viewed as having one foot in this world and one foot in the next, and they occupy a very special place in that society. To take that even a step further and to tie it with the art that we talked about last night, could it be that creativity or that some positive attribute, skill, is associated with epilepsy? We wouldn't necessarily call that a comorbidity. It's not morbid. But if that is the case, and that remains to be proven, might that have some positive impact on society? Somebody like Van Gogh, who I think clearly had epilepsy, did he make our world a better place because of his art? The artists whose works I showed last night have some indirect effect on on society, on evolution in a more societal sense. So let's keep in mind that there may not only be life-limiting, quality of life-limiting complications or associations of epilepsy, but potentially enhanced abilities or greater than average qualities or characteristics that are associated with epilepsy as well, that conceivably could be viewed as a benefit, in terms of evolution or in terms of society. So with that, I will close the morning session. Did you need to make an announcement? Excuse me? So Norberto has some housekeeping announcements. Thank you to our panel.